We are here to share knowledge and skills. We are here to dive deep in the rich experience of Dr. Jackson. And it's a great pleasure to have you, Doctor. It's a great pleasure to have CEO and co-founder of the Operating Room Global. It's a great pleasure to have you, Danny Hakoriman. It's a great pleasure to have you, Japol. It's a great pleasure to have each and everyone here on the board. And please, if you feel some energy, share the energy with us in the room by saying hi in the chat, and probably your occupation. We need to hear you. We need to see how many healthcare professionals and which department is represented today and which country. So it's a pleasure to have you. And in a few minutes, we'll be starting off. Awesome, awesome. I can see some people have joined us. And without further ado, we welcome Danny Hakorimana to share the bio and the introduction and the description of our presenter today. So Danny Hakorimana, you are warmly welcome.
Oh, thank you very much. I'm happy to be around today, Alphonse and team. So I would say again, you are most welcome for this webinar of today with our senior Dr. Jackson. So, so his short biography, ladies and gentlemen. Please join us in welcoming Dr. Jackson Kwizera Ndekezi, medical doctor, consultant, and nutritionist at King Faisal Hospital in Rwanda. And he's also a fellow knowledge translation in chronic pain management. And also, Dr. Jackson is also a dedicated educator, serving as lecturer at College of Medicine and Health Sciences at University of Rwanda. And there at University of Rwanda, he held a position of AG Programmer, Director of Anesthesiologist Postgraduate Program. As you see, our speaker today, he has a very strong CV. So additionally, he serves as Treasurer for Society of Anesthesia and Critical Care Physician in Rwanda. And Dr. Jackson also is an expertise on patient safety, safe anesthesia, and chronic pain management. That's making him a valuable speaker of today's webinar. So Dr. Jackson, he's not only a distinguished medical doctor professional, but also he's a chairman of TORG in our chapter here in Rwanda. So his leadership and expertise in anesthesia critical care makes him an invaluable asset of our community globally as TORG Global, and also he makes him as a special locally as to our chapter of Rwanda. So, ladies and gentlemen, kindly join me to welcome Dr. Jackson for his insightful expertise and Dr. for this discussion of today. So, Dr. Jackson, you are most welcome for today's discussion.
Thank you all for having me. Just a minute, I'm sharing my slides. So that we just take off with all the slides and go ahead. So in the meantime, thank you for having me, and I think I will not take all the 40 minutes as you presented. It will be a short presentation, but having a lot of discussions in I will be allowing some ideas from you, and then it will be an interactive session. And we'll be having some time to just have discussion via the chat. And I hope you will be just enjoying this presentation. So in the meantime, please bear with me as I'm through sharing this. Can you see my slides?
Yes, we can
Yes,
see.
Jackson. Yes, yes, we
Okay.
can see.
Great.
Yes, I can.
Great. So I will not be talking about economics as it is, but what I need to share like a knowledge to all of us is how we may just involve like thinking about the costs of what we're doing, and in terms of a resource as a nation resources, in terms of what the patient is just kind of spending on our blood transfusion, and what the institution like health institution is just spending to how the blood transfusion is being given or being managed to our daily patients. I just want to share my plan of the day. So in fact, we'll be starting to define what is patient blood management is, and know what are the components, and at the end we'll see how we can just incorporate the economic aspect of it. And after that, we shall see what we can do to just minimize or economize what we are giving to the patient. And at the end, we shall have like some example of how we can do patients' blood management in our daily practice. And at the end, we shall have conclusion. And as I said, we will be having kind of interactive sessions in the meantime during the presentation. So what is patient blood management? The American societies, European societies of critical care, and the Asian parts, they just with the WHO put up a very good definition that is currently how we use evidence-based multidisciplinary approach to caring for a patient who needs blood transfusion. In fact, it's just how we do manage giving blood to someone, thinking as a group, as a team, and then we approach how we're gonna give this blood to such a patient. From that, see this as how we manage patients' own blood in a unique natural, own patient blood is a unique and natural resource that we can be using to economize how we are transfusing our patients in daily practice. And from that, we need kind of team working to economize how much we give to patients. From that, you need a decision making on when to who, and how to transfuse blood and its components in an appropriate manner. So as I said, you need kind of having three components in its entirety, like how you optimize red cell mass and minimize blood loss, optimize the anemia tolerance. If the patient can really tolerate anemia that the patient has been having, or you minimize the blood loss that has been on, or just keep the red cell mass, that would be really helping. How can we do that? You need to know your patients. That's where you have a pre-op evaluation of the patient, but mainly focusing on how the hemoglobin and hematocrit of the patient is, and then correlate it with what we call hemodynamics. Now, you will also need to promote blood recovery. That means what has been in place be optimized to the patient to the extent you do not need too much to transfuse. When it comes to minimizing blood loss, that's where the WHO put up some protocol where you may see that you need to define what is anemia and what is really kind of trouble ring to any patient that you have, despite the level of anemia that you have to the patient. Perioperative, you need something like efforts help you out having all these. You need to predict how much blood you will be needing or how much components you need. Again, you need to look up to factors like, do I have to take samples? Is my patient really feeding so well? What are the labs showing me? What techniques do I need to use to make sure I do not give too much blood to my patients? So in our daily practice, you need a diagnosis of what is anemia, and then target your management, and then just have goals. Mainly, you need to conserve blood, restrict transfusion, except in cases where you have like acute and massive bleeding. So from that, you just reduces losses and avoids unnecessary transfusion. As we said, it's not a one-man game. You need a team. Like a curious question, you will go to the charts and then just put up some answers to my question. How long does it take a surgeon to your places to prepare a surgical patient? A week, like 1 month. It depends to cases. Just go to the charts and give us some answers. How long does it take a surgeon into your places, into your working place to prepare a surgical patient? How do you optimize your patients? How long does it take you to optimize such a patient? Go into the charts and then provide some answers so we can just share experiences. Like, have you ever been forced to halt or stop or postpone surgeries due to anemia? Tell us. And then afterward, we shall see what is the ideal timing to prepare, like an SA2 patient before operation, and then optimize the level of anemia. Go into charts and tell us. I can't see some answers from you. Maybe you're still thinking about how long it takes a surgeon to prepare a patient, a surgical patient. So without taking much time, or maybe one has shared the experience. I can see Gaston saying always days. Someone said 1 to 2 weeks. So without taking too much time, as I have told you, it's not a one-man game. You need to prepare a patient having like on board the lab team. If the patient has severe anemia, you need hematologists on board. You need people from the blood bank. Sometimes you may just involve the anesthesiologist who will be giving blood. I'm talking like someone who will be like a third party, apart from a surgeon. So we need a surgeons. If it is a ped patient, now you need a pediatrician on board. So as you can see, you need team around you. Do you think administration can be contacted? Yes. Sometimes you need an ambulance or someone to go pick up blood from the blood bank and then bring it to your institution. I don't know how your health systems are built. In our country, sometimes you need like a drone. Blood are being transported by drones to different parts of the country, and then you have blood like within 30 minutes. So you need that part of channeling blood to you. So look, as you can see, we have to make a team around you. So you decide when to give blood. Is it needed? How much blood? What are the components are needed? Now, from that, we're gonna assess how anemia is really serious to our pre-op patients or a perioperative patients. This is a study that was done in Austria and in Germany, and this study was just kind of assessing globally how anemia is prevalent. And remarkably, you can see that the sub-Saharan Africa have like almost half of the patients will present with anemia. And guess what? 40% of all the children of the patients age 6 to 59 children, sorry, age 6 to 59 months are having anemia. What about pregnant women? 37% of them are anemic. And when it goes to the adult age, 30% of the women are having anemia. Now, looking at how prevalent this anemia, except like in developed countries, the Westerners, when you go to Australia or some other countries, you can see that they do not have anemia. It's multifactorial cause. But when it comes to saying that we have a lot of anemia, now we need to start thinking about how we manage our patients. This will take me to how much time you need to prepare your patient before operation. Now, looking at how this anemia is, you need a team around you and then prepare the patient. The study done in US, we're just saying an SA1 patient with no other comorbidities may be looked at like 3 days before operation and then optimize their anemia and tolerance to anemia. How we do looking at them, look at the age, sex, Look at the comorbidities, sex or gender. And then, is the surgery a major surgery or just intermediate? This will help you to decide, is this patient needing blood? What is kind of a surprise is here. This is a study that was done in US, Florida, and then it was kind of a one blood study. And then it was just looking at how having a low HB does not define to be given blood. If you judge that your surgery will not really make too much blood losses. And now look at how your patient can tolerate stress, surgical stress, perioperative stress. Now, how you gonna optimize your patient? And then perioperative, what is going to be lost, repressed or not? Now, post-op, you're gonna assess if this patient is going to be really tolerate this loss. Now, looking at this study, you can see that this study reveals that you do not need to just transfuse blood basing on laboratory values, but you need to transfuse the patient basing on how a transfusion may affect the patient quality of life. Now, here you need to think about the potential variation, the effect of blood transfusion on how the patient has been being fatigued, what we call functional status of the patient before transfusion. If the patient has been having like an HB of 5 for long ago, he's working, he's active. Now, if the surgery is not going to take too much blood loss, why giving too much blood or blood component for transfusion? Therefore, understanding whether the effect of transfusion on fatigue varies by patient baseline fatigue, or may help clarify whether transfusion during hospital is needed or not. A next study reveals that this is a study by Westcott, his colleague. It's too old, this study. But look at what it revealed. It is showing that a healthy individual who can tolerate isophoretic HB values around 5 grams per deciliter, sometimes astonishing. But what we need to know is if really I can deliver oxygen to tissues. For those who are knowing what we call oxygen delivery equation, that's always dependent to the cardiac output, hemoglobin level, how the patient saturates. This will be physically allowing your oxygen to be transported to the tissues despite having low hemoglobin. Now, looking at this study, you can see that having a moderately elevated heart rate with low HB didn't really show that perioperatively changes too much to how the stroke volume has been in, despite keeping the low HB. Or in case you have the cardiac index, which is kept in normal ranges, despite having low HB all over. That puts like a conclusion on how we need to assess how the patient tolerates or kind of tolerating these losses despite having HB, which is lower than the what we call our minimum HB level that can just go on our guidelines nationally. Now, how can you reduce it or optimize your patient operatively? A study done in Europe revealed that there are some of the implementation checklists that you can be using, but having a team with you. You need to set goals and then show implementation plans, make a team with you, and assess what you're just putting down like a plan that helps you to just scale up what you're doing. For example, there is a checklist you can see on your screen that you need, like, is it supported by the medical director of the administration of the hospital? If you just go put up how you're going to manage blood transfusion, patient blood management. If I don't need to be giving too much, do I have a multidisciplinary team with me? Did I train my fellow physicians, nurses, whoever, surgical ward team, and did I really enhance viability of what we have into our settings? But the very important thing that I want you to see is, like here, when you just start thinking of optimizing the physiological condition the patient may have, like pH, temperature of the patient. As you can know, during the perioperative period, when you have like hypotension may lead to coagulopathies, and any coagulopathy leading to too much blood losses. At least make sure you have tight temperature, hemostasis. Then some of the developed settings, you have self-salvage devices. Sometimes you just discuss with the surgeons how you can salvage much blood. Work on hemostasis, like the venous arterial blood management. How much do you sample for your blood culture? Maybe you'll be telling me how much do you draw for blood culture. If we can make sure we just minimize what you've been given, just taking like a sample, if you've been taking like 6 ml for blood culture, and then you're going to take like 3 bottles to a PED patient, imagine how your anemia gonna be at the end of blood sampling. So you need to have all these measures put up into practice, and then have like transfusion algorithms. You need guidelines in place. So you just make sure you minimize too much blood losses to your patient. Here comes how you can diagnose if the patient is anemic or not. So pre-operative, you need to have the indication of surgery, of course. Now, assess with your anesthesia team, like 4 to 5 weeks prior to surgery. If you have anemia now, you need to think if this anemia is normocytic or microcytic. Macrocytic, that means you have a kind of vitamin B12 or folate deficiency, so it is there. If it is there, now you need to think that you have renal insufficiency, liver insufficiency, or endocrine deficiencies, or some drug that can be leading to vitamin B12 or folate deficiencies. Now, when you have megaloblastic anemia, there are some measures that you can be taking. So when you have normocytic or microcytic anemia, that's where you start thinking about ferritin and everything. That's all about how you just provide iron supplementation to your patient. This needs a team around you. You need a very good working laboratory. You need to keep temperature, hemostasis. Sometimes you need point of care monitoring. That's where you need to know how your patient can cope with physiological changes that are attributed to anemia. Where you have self-salvage machines, that's very good, and can help. Looking at the image, sometimes we think that we're doing so well, and yet we kind of ourselves consuming blood from the patient. That's where we just start thinking our trends and routines, our customs, and how we work, what we do means. I just asked you a question: how much blood do you draw for blood culture sample? How big are your vials for blood culture sampling? how many times do you sample blood for like blood gas analysis? What is the quantity of blood is needed for your blood gas analysis? I can give you an example. If you have an ISTAT machine for just blood gas analysis, it is requiring like 1 drop of blood. But when you go to healthcare providers who are now drawing like 3 mils of blood, why the 2 more cc? Even 1 drop count. A study done in Europe again, and then it was published in the British Medical Journal, revealed that you may reduce blood transfusion by giving iron supplementation. That's why this study took us back to how much you can optimize your patient. For example, if you're just going to do a major surgery and this patient really needs blood. So of course, if you meet up the patient like 4 weeks before, start supplementing iron, it can be given IV or Peros, and then see how it improves and reduces blood transfusion. Looking at how this study is showing a very good outcome and reduced blood transfusion. With this trend on the image, you can see that on the left side of this image, it didn't show up too much effect, but when it goes to this study by the subtotal blood that you can be needing, you can see that it just showed a tremendous effect on how much you can need in case you just give iron supplementation before operation. Now let's see in terms of money. A study done in US by Narosinski in 2022 revealed that you can see that giving red blood cells which are washed up with no white cells in there, the minimum price that you can be giving is just $208 US. I don't know what price it costs our health system here in Rwanda. But look at the apheresis rate. It's more than my salary, actually. When you just pathogen reduce the apheresis rate, I can see this is more than a consultant, anesthetist working in our health system. So this is more than my salary, actually. So when it goes to fresh frozen plasma frozen within 24 hours, or precipitated blood, you can see it's too much of money that you can just be paying out to have these products elaborated and be ready for your patients to be transfused. So in doing whatever we do in giving blood or requesting blood, what can we do to reduce these losses in terms of money that is needed to be really catered for? Back to our country, we have the zip line, which is just transporting blood from like 70 miles away from the station to almost all the rural hospitals in our country. Now, think how this zip line is costing a lot of money to be just distributing blood to all the peripheries. So into our chats, maybe some of you can be sharing experiences how you're managing blood transfusion or the components of blood transfusion of blood, and how these transfusion costs and how you tackle the high costs that is being invested in blood processing and transfusion. What else can we do if we can't work on pre-op optimization, now perioperative by reducing losses, in post-op reducing losses, and making sure the anemia can be tolerated instead of just giving too much blood? Into the chat, tell us, what are you doing into your health system at your working facilities? Some seconds just to see and hear from you. Any idea on how you just dealing with managing patient blood transfusion? Remember, giving too much blood to the patient can just be putting all the complications that we all know. Now, how are you dealing with how to minimize blood transfusion or give blood that is really needed? What do your health facilities work on? Make sure we manage these losses from blood donation, blood conservation, blood storage, blood processing, some of the blood components which are very rare. How do you manage? Any idea? If no other ideas, this is preceding my last slides. Do you have any input, any question? And remember, do not take this message away, having a confused tense upon you. I can see sometimes ask the patient to look for donors before surgery, and then look for patient blood type within the bank. Okay, that again can help you. But again, is this going to minimize the needed blood and how much you just give to the patient? Are you going to look at how your patient can tolerate the lower HB levels and you still give surgery? Any other idea? If you know other idea, just conclude. I can see some messages into the chat. I can see use of some processes to reduce blood loss during surgery, like diatomy would help. That's really great. Diatomy is very, very great. The other thing I can see that Jean-Paul said, ensure adequate hemostasis intraoperatively. That's a very good input, I can assure you. In fact, you need to make sure your patients operatively have a very good eye now. He's not at risk of bleeding losses. And then intraoperatively, make sure you have like diatomy that helps you. We are very happy in some institutions, they have like a bipolar, which is very good at minimizing blood losses. And sometimes you need to make sure the temperature into the operating room is really within normal ranges that can't lead to quadruparies. What else can you do? Like warming IV fluids. That's really great. Warm crystalloids may help you keep a good temperature. Then the other thing is sometimes some sciences support what we call hemodilution before operation. So when you lose blood, you just come up losing a very little percentage of the initial blood. Like using of medication like local anesthetics with adrenaline, verapamil, or seclone. Again, local anesthetics may really minimize all these. I can see someone just dropped a very good point. Yes. Mary said, are you screening or diagnosis or undiagnosis like screening for anemia, conduct hemoglobin test 30 days before elective surgery? I don't know if it is really being done in every settings. I can see someone said again, identify underlying causes like assess iron deficiency, chronic diseases, nutrition deficiencies. That's really great. And then treatment strategies, iron supplementation, erythropoiesis stimulation, multidisciplinary approach, collaborative care, individual risk assessment. That's really great, Mary. Thank you so much. And from that, let's put up some key messages. Patient blood management looks for evidence-based efforts and a teamwork. You need a team around you. You can't do all this stuff that Mary shared with us without having a team around you. Remember, anemia management needs a holistic approach. You need to treat anemia, looking at the patient as a whole. Now, minimize costs and adverse effects of blood transfusion. Minimizing that needs a balance from benefits to effects. But again, look at how the patient can tolerate the minimum HB that you can have. Some of you, before I conclude, said ensure the patient clotting time is within normal ranges. And the other said also the OR nurses should prepare the surgery adequately to help surgeon minimize operation time. Thank you so much, Jean-Paul. This is great. We need a team around us and make sure we have in mind to treat patients, but again, minimize the cost that the patient is having, minimizing costs that our institutions are putting up. Now, thinking globally, minimize the money that is being invested in this by your countries and the international organization. Thank you so much. This marks the end of my presentation. Questions, additions are welcome. Thank you.
Okay, thank you so much. That was a wonderful presentation. Oh, please, now we have to ask our question. If you have any question, please do use the chat box, or you can raise up your hand and you'll be called upon to ask your question.
Thank you very much for this presentation.
Is there any question? Let's use the chat box or raise up your hand. You'll be called up for your question.
All right. During the presentation of mentioned that for some circumstances, HPO is operating. In my mind, I was thinking like, how does this different with time? Like some circumstances that their body feels, or how does the body cope with this?
Someone who has been asking the question is speaking really, I couldn't catch you up. Can you speak up? So in the meantime, you can see like Jean-Paul asked about how blood recovery is being done. In fact, blood recovery, starting with my presentation, I said someone's blood is a unique, dissociable blood bank that you can be using. So in doing so, there is what we call cell salvage. It's all about having blood that's being lost during surgery and then process it and transfuse it to the same patient. In fact, that's what we call autologous blood, but by minimizing what is being lost. Capture what is lost, process it, and then return back by transfusion. It is best being done in cardiac surgeries, but again, you can again apply these blood recovery principles on how you minimize what's being lost by just minimizing like the size of the blood sampling bottles, all these processes that, all the interventions that we are doing by minimizing what we do, because it's kind of recovering what should be being lost to make sure we minimize what is being lost and make sure we just stay with it. We just recover it.
Okay, before that question, there is also a question here from Mizua. Mizua, the person he asked the question, remind us how is apheresis platelets by Rachel.
How is apheresis platelet?
Yes.
So Rachel, apheresis platelets, it's a product of how they process platelets and wash them from the other components of blood. In fact, the apheresis platelets is an end product that is being put down after processing the whole blood and removing the other components. And it's mainly having washed platelets. They wash out all the other components of the blood and then you stay with the platelets. And this is made in case you need to prevent someone to get like allergic to other components of the blood. And this is again preventing what we call transfusion reaction in case. The other component in it is that apheresis platelet is used like a common term that helps us to have like 4 to 5 units of platelets. You're gonna see on our sheets for blood requests, you're gonna see that down there is what we call apheresis platelets. And sometimes you're gonna see that there is adult platelets, adult apheresis platelets. It just means like the volume and the processing effect of having washed platelet with no other components from the blood. I don't know if I'm clear with that.
Yes, thank you so much. Okay, the next question from the chat box says, how can you relate zipline blood delivery with the outcome? Then it's also asking for any recommendation about this.
Okay, great. As I told you, zipline is helping out transporting bloods and then just send it to most of the rural parts which are not accessible with the usual transport. And then just helping a very quick delivery of blood components. With that, on one side, it's very good in case you have acute or ongoing bleeding, because you have very quick response. You need blood and quickly being given, like within 30 minutes, you have blood with you. But when you put up economic aspect of it, it's costly. It requires a lot of technology. You need some people like human resources to use that. And then you need technology, you need all this packaging. All this may just be taking too much money in case you need blood for not an acute or ongoing blood loss. So in doing this, you need like blood donation guidelines and how you need to incorporate economics in how you take blood, process it, and go to the zipline for storage. Then use all this technology to send blood. It's too much of money, too much of resources. So if it is not just for acute bleeding, again, you need to think twice. Do we really need some other efforts to minimize how we use our zipline and blood delivery? That's a question that I put it down for my fellow Rwandans and wherever they use zipline for blood delivery.
Okay, sir. Thank you so much. The next question says, how long can the patient take iron supplements before the surgery?
With the study that I shared, in fact, it requires like 1 month, and then it showed that you may be having iron supplementation. When it is IV, it takes like 15 days to have your hemoglobin going up or almost to an additional 1.5 gram per deciliter that is added to your hemoglobin, just being given like some dose per kilo to the patient. So now when you just take it per dose, it takes 1 month to have its effect and just increase the hemoglobin level. So that it will depend to how it just start with the patient. And that's the reason why I was asking how do your surgeons prepare the patients before the operation? You need to have time and then reduce the costs that you're just putting up for blood to be given to patients instead of having like this less expensive iron supplemented to your patients like 1 month before being operated on.
Okay, thank you, sir. The next question says, the blood donation policy affects the economic viability of blood services. So he wants to know, do blood donation policy affect the economic viability of blood services?
That's such a very good question. In terms of economics and viability of blood services and everything, I think blood donation policies may be positively affecting this economic viability of how we can just put up guidelines and everything. Look at how you need people from the blood transfusion center going for campaigning for blood sampling, storage, processing, now delivery to the patients. All this requires human resources. You need equipment. You need people sitting down and working on that. You're gonna see that in every country you have blood donation centers. Just you have like you have to make communications, going for camps and collecting blood, processing them. Again, if we have like policies that can just putting up what is really needed, how much do we need, how can we really salvage what we have in place, how can we incorporate the economic aspect of how blood is being processed, donated, processed, and being given to the patient. I think these policies can be positively affecting economic viability of our blood transfusion services.
Okay, thank you so much, sir, for the answers you have given. That was so wonderful. Okay, the question I want to ask is based on some hospital setting, some private hospital settings, especially in low middle income country like in Nigeria where I am, Some private hospitals, they lack some of these multidisciplinary team that will help patient management of blood. So what do you recommend for this kind of hospital setting?
So as I told you, mitigating how the economic aspects may be incorporated on how we do patient blood management in our institution. I think having like awareness on this will be helping whether private or public hospitals work. You need awareness on this, plus training people. Second, involving the stakeholders, because stakeholders will really help out. Again, after that, the administration or the political will be involved, because the government is just putting a lot of money in processing like 1 unit of blood. But again, when it goes to their private, I think all the private hospitals are under the administration of the Ministry of Health, wherever it can be working and operate. So that's the reason why I think awareness, training people, and then starting this patient blood management, like workforces or task forces in every institution, can be helping out and mitigate the economic aspect of it. I don't know if I'm clear with that.
Yes, it's okay. Thank you so much. Okay,
You're
another
welcome.
question from that box. It says, which type of iron supplement is best for intravenous use?
So, looking at this study with the European, this study showed that there is it's kind of human-based iron, and some of the industries were just putting up, but I will need to check if they use human iron, which is processed from human body, of course. But again, there are artificial iron that were put up, but this study used human iron, kind of human-based iron. They were just extracting from human body, and then it was just increasing this. But again, whatever iron can work, to me, may be reducing what really is being given to, what is really being invested to have the blood being given to the patient.
Okay, sir. Okay, the next question says, what is the message to Jehovah Witnesses from low middle income countries where blood products substitutes are not available?
So, in fact, that's a very good question to them. Before, when I was a GP, I was really not thinking about what is really needed. Do I really need to give too much blood? If they deny to give it, can I force them to just have it? These are all the kind of clinical dilemma decision making that comes in. But thinking about how meeting into your clinic all the patients and then start mitigating their anemia and maybe supplement with iron, that would be a very good practice to the Jehovah Witness people. But again, when it comes to acute bleeding or acute blood loss, here comes where you need to come up having a resuscitative instinct that comes into your mind and then see, will I leave this patient dying? Some of the Jehovah Witness people will be having papers or cards saying, I do not take blood, but again, if I'm losing this patient, I don't know what is the practice in other countries. Maybe that's the reason why Gaston has been asking such a question. But sometimes when they are are things that you need to observe and then work and
I guess it should be a network issue. Let's wait a little bit to know if okay. That was a wonderful presentation. I would like to invite Dr. Gaxton to give us a closing remark on this wonderful presentation. The floor is yours, Dr. Gaxton.
Thank you very much. Thank you for the and I think everyone enjoyed the presentation, and it's a big issue about transfusion, and economic piece of it always matters. Actually, I asked the question about the Jehovah Witness because I know it's a big deal, like seeing someone dying, because in high income countries you find people, they have substitutes of blood products that are natural, accepted by Jehovah Witnesses, and factories, they do that, even synthetic, that they can help patients with need of transfusion. But in LMIC, they suffer, actually they die because of the beliefs, but we know what we can do for them. So recommendation, iron supplement will be good, but in the case of emergency, we might face some issues. But anyway, so it's a big issue, mostly in LMIC, where policies to delivery issues and limited centers of blood banks. So I think the thing we should advocate for that and make it as a priority, because we are losing some patients who need blood transfusion. So thank you everyone for participating. It was a good presentation, and I'd like to say thank you, our friends from Nigeria, our friends from everywhere, our friends from all over the world attending this webinar. This is really amazing. Having more than 30 people attending this, it's really amazing. We are so humbled in like Rwandans to have you guys following us, coming to this. It's really amazing. And I would love to say I already miss Nigeria. I was in Lagos and I really miss it. And I think it was really good. We had a nice moment. We had a very good conference, and we still have some memories, big memories from there. And so thank you, Madam President, to be here with us. And I think for the next webinar, will be communicated soon. Thank you very much. I think it's late for some people, but thank you, Jackson. Thank you, Jackson. If you want, you can put to the next webinar. Yeah, just pick a topic and we can give to you. Thank you. Thank you very much. I would just appreciate everyone's participation and wish you all the best. Thank you.